today's video, we're talking about Lutetium-177, actinium, and we're also talking about potential new prostate cancer treatments that we hope to see down the line. Things like using a lead molecule or antibodies in prostate cancer, things that are used in other cancer but are now being used in prostate cancer. So we're sitting down with Dr. Nat Lenzo, who is a nuclear oncologist, and he also is an internal medicine doctor. He has been really instrumental in a lot of the studies that we have seen when it comes to lutetium and actinium. He's doing a lot of research in Australia, and he's going to break down these treatments and so much more. I hope you find this informative. Thank you so much for being here today. We really appreciate you. Now, you have come quite a long way, all the way from Australia. Now, I met you at our 2019 conference in September here in LA, and you were so kind to answer everyone's questions. How did you even get into this? Because you are in every trial I see when it comes to lutetium and actinium, and you had Theranostics and Genesis Care, and I've read your bio, but I'm thinking, did you wake up and decide that you were going to be this like revolutionary end-stage prostate cancer expert when you were young? Like, this is pretty incredible.
No, I didn't choose to become a revolutionary in prostate cancer. Like most things in life, sort of fell into it in many ways. Always knew I wanted to be a physician when I was in medical school, so physician rather than a surgeon. And so I went into internal medicine training, and then through that did quite a lot of oncology in internal medicine. But it was in the days where outcomes were not great. Chemotherapy was very toxic. It was quite a disheartening experience, actually, as a junior doctor seeing that. I then went into nuclear medicine due to serendipity, really. I was covering someone who had to take maternity leave, and they said, "Do you want to take my nuclear medicine job for 6 months?" And I sort of really enjoyed it. So I dual trained in internal medicine and in nuclear medicine. And then just by luck, I did a few rotations with some people who are now considered probably the visionaries in nuclear oncology or theranostics, so people like Richard Wall at the University of Michigan, where I did a fellowship, and Professor Harvey Turner at Fremantle Hospital, who was doing a lot of very interesting work using targeted therapies. These were in the early days before really the pharma companies got involved. And we were seeing some very good results, but I think probably more importantly, we were seeing very few side effects from the treatments. So I'd come from training in hematology oncology, where I was making people really sick, to now giving them therapies which were probably just as effective, but not making them sick, so that they could enjoy their life and spend time with their families, do things they wanted to do. That's probably the revolutionary part of it. That was the enlightening part of it. And I've been very fortunate that in the last sort of 10 years, through different organisations, initially at Genesis Care, now at ICON, people can see that this has got a real role in the future. So they've supported my endeavours, my research endeavours and my compassionate access programs. So I have a very fortunate job. You know, I get to treat people from all over the world, and I get to use a lot of cutting-edge technology.
The first thing I want to cover, because I know once patients watch this interview, they're going to want to know how to access you and how to access the resources and the doctors that you hire within your companies. So can you quickly just give me a breakdown of the companies that because you had Theranostics and then Genesis Care and now ICON. Are they separate companies, and how can patients access you in order to get these types of treatments?
I started a company called Theranostics Australia back in 2015. And that was on the back of seeing what was happening with gallium PSMA and then lutetium PSMA. So we started doing gallium PSMA imaging in Theranostics Australia actually in July 2015, 9 years ago. And then because we had quite a lot of history in gallium imaging followed by lutetium therapy, particularly for neuroendocrine tumours, so we did gallium dotatate and then lutetium dotatate, it was very simple. We had the setup, the chemists, the infrastructure that allowed us to do the imaging agent and also the therapeutic agent. So we very quickly sort of transitioned to that. So we started lutetium PSMA in Theranostics Australia. I think we were the first in Australia to give lutetium PSMA in October 2015. 2018, my company was bought over by Genesis Care, and I remained with Genesis Care till last year, or early part of 2024, where I left Genesis Care, and then a few months ago I signed on with ICON. So Genesis Care, we're a global oncology company. They're now based in Australia alone, whereas ICON is a global organisation. That was probably the main reason I parted ways with Genesis Care. The global footprint of what we do, I think, is what I really enjoy. I've done a lot of work in Southeast Asia and Indonesia. I was fortunate enough to work with Genesis Care when they did expand into the United States and into the UK. And now ICON are expanding into Asia and into the UK. And with that, we're setting up Theranostic centres. So we have Theranostic centres in Australia, we have Theranostic centres in Singapore, we're setting up in Malaysia, and we're setting up in the UK. ICON is purchasing PET cameras, SPEC cameras, because those are really our tools of our trade. We can't really do our work without that imaging equipment. So if someone needs to contact me, then ICON, they can contact me via the ICON website. We have information about our Theranostics program and the sites where we offer theranostic therapies.
That's awesome. So we'll go ahead and link that in the description below and in our comment section so patients can access that. Now, do you see patients yourself?
Yeah. I spend probably half my working life is consulting patients. Half of it's consulting patients and half of it is probably being involved in the research. But when I say consult patients, some of that's also reporting imaging studies. I report PET scans, SPEC scans and so forth, but I'm consulting patients via Zoom or Microsoft Teams, and sometimes in person, most days of the week actually.
Before I get to my next question, I just wanted to remind you that we have an in-person prostate cancer patients and caregivers conference coming up this September, and you can learn more at pcri.org. Also, click that subscribe button, because when you do this, it tells the YouTube algorithm that this video was helpful for you, and it'll push our videos out to other people who need them. And you can also support us financially at pcri.org/donate. Now back to my conversation with Dr. Lenzo. So there are two terms I want to define for the audience. We have people from all walks of life, and I just want to make sure that they're understanding really and getting the full depth of who you are and everything that you represent when it comes to the research that you've done, which is impressive. And I'm very excited to have you, because we see things like Pluvicto and Actinium and all these saving lives. And especially when you're talking about the lack of toxicity and patients not having as many side effects. So we're really excited to get into it today. I think that the two terms, I saw in your bio, it says nuclear oncology. So it's nuclear medicine oncology, right? And then there's theranostics. Can you define those two terms to a more extensive degree?
In some ways, they're interchangeable. So nuclear oncology is really the use of nuclear medicine isotopes, be they therapeutic or diagnostic, in the oncological space. Theranostics is, in its real term, is using an agent where we can get an image, so for instance a PSMA imaging agent, and then we can also, through some manipulation, turn that into a therapeutic. We sometimes have what we call pure theranostic pairs, and the classical one is in thyroid cancer. We have iodine 123 or iodine 124, which we take an image with, and then iodine 131, which we treat. It's iodine, they're exactly the same characteristics. So the imaging characteristics are 100% like the therapeutic characteristics, will go to the same place in the tissue because they're both iodine. And that is a pure theranostic pair. When we talk about things like Pluvicto, we have a PSMA imaging agent, but it's not a lutetium PSMA imaging agent. It is either a gallium or a fluorine type of PSMA imaging agent, or nowadays even copper type of PSMA imaging agent. That shows us the target. Now the target is the same one that Pluvicto will go to. It's a slightly discordant theranostic pair. They're hitting the same target, but they're not exactly the same type of isotope we're using. One's an imaging isotope, gallium, copper-64, or fluorine-18, and the other one is a therapeutic, which is the lutetium or actinium or lead, or one of the other agents that we use as a therapeutic agent.
So how do you get the therapeutic agent to bind to the imaging agent in order to be effective towards those targets?
We have a molecule which, if we take, for example, the 617 the Pluvicto molecule, has been designed to bind to the PSMA receptor, which is on the surface of prostate cancer. We then have what's called a chelator, a little linker, and then to that linker, which is attached to that molecule, we then put a different type of radioisotope. So I can put a gallium on if I want to take a PET image. I can put a fluorine on if I want to take a PET image. But if I want to give a therapy, then I have to decide, am I going to put a lutetium on there, which will give me beta radiation as a therapeutic, or am I going to put actinium on there, which will give me alpha emitting type radiation? So the actual molecule that's binding to the receptor on the tumour is the same molecule. But what we're doing is we're changing the payload, either an imaging payload or a therapeutic payload. That's really the difference. And when we talk about PSMA 617, that's a molecule that's been designed to hit that PSMA target. But there are other molecules. There's PSMA INT, which attaches, it's a slightly different chemical structure, but it attaches to that same PSMA receptor on the tumour. Or if we look at the Clarity compound, the copper bis PSMA, that attaches also to the PSMA molecule, but it's a different compound that they use to attach to the PSMA on the tumour. So that's how all these therapies basically sort of work. We have molecules that have been designed to attach to something either on or in a tumour cell, and then we just use that as a carrier to bring our payload to the cancer.
Well, you said so many things that I'm so excited to talk about, but let's, staying on Pluvicto. So we've had Pluvicto approved here for a couple of years now.
Well, what's interesting, I didn't actually do a lot of Pluvicto research because Pluvicto was very tightly held by Novartis, who were running their trials. There was a lot of Pluvicto research done in Australia. A number of the phase 2 trials were done in Australia. Most of my work, interestingly, was with the PSMA INT, which is the Curium product now. But when we were using it, wasn't actually owned by anyone, open access. So we did a lot of work in looking at safety and tolerability, which is really the right way to go about it when you're first using a product. You really want to make sure it's safe. What are the side effects? What are the toxicities? There are no agents that have got no side effects or have no toxicities. So we looked at a lot of the potential issues that these agents theoretically could bring to you. So we know that they bind to the salivary gland. So how much salivary gland toxicity were we seeing? We know as radiation can affect the marrow, how much marrow toxicity were we seeing? Because they're renally excreted, we were concerned about renal toxicity, where your kidneys getting a hit from the radiation. So we did a lot of work collating data on hundreds of patients. And really our data mimic what they were seeing in Germany and then what was shown in the Vision trial, that these agents are actually pretty well tolerated and their side effect profile is quite manageable. They do have some myelotoxicity, your blood counts can drop, but it's reversible. Rarely do you need to intervene with the small molecule type therapies. The kidney toxicity is not there, but it seems to be quite minimal. But you learn a lot by doing these trials and also by the real world evidence. So we understand if someone's already got bad kidneys, we could make it worse with these agents. So you start understanding how to use these drugs. The salivary gland toxicity that everyone was worried about, we didn't see a lot. It was definitely there, but we didn't see a lot with lutetium. It is a cumulative side effect, but there are other confounding factors. It's also related to how old you are, what other therapies you've had, what other disease processes have you had in the past. They all contribute to that salivary gland toxicity. When we started looking at actinium, which we've been using since 2018, that's where we started seeing a lot more toxicity. Efficacy was greater. It's an alpha emitter, much more potent, but much more salivary gland toxicity, more renal toxicity. So we were actually seeing some toxicity to the kidneys. We were able to publish our work with Mike Satheki from South Africa in a large study, which was published earlier this year in The Lancet. So we've been lucky enough that through our compassionate access scheme in Australia, we've been able to use the data that we've collected on patients who really didn't have many options to try and work out what is the safety and tolerability and to a degree the efficacy. The real world data that we do actually often drives some of the research questions. We were able to show that in certain populations these therapies seem to work better. And all of a sudden that leads you to say, well, this is maybe a population where we should actually do a really proper trial on and see if we can get an indication that can get approved and eventually get reimbursed. The trials that I've been involved with, the pharma-sponsored trials, they're fantastic in that patients get access to all these agents for free and they get latest agents. But they are complex, they are very time-consuming, take a long time to set up, take sometimes years to get the final results. We're fortunate in that we can also offer compassionate access for patients who can't get on a trial, which isn't common in many parts of the world.
Well, no, we so appreciate those systems because we see many patients get access to them. Now, when it comes to Lutetium-177, to my understanding and from what I've learned here in the US and just talking to patients or interviewing physicians, we see that it works really well in like 1/3 of patients, somewhat well in another third, and then not at all in another third. And you've been giving it since 2015. So does my understanding, is that accurate? Is there more delineation between those systems and in those different sections of those patients?
It is really quite interesting when we look at the original data that came out of Germany, the real world data that came out of Germany, the real world data came out of Australia, the phase 2 data that came out of Australia, the Vision phase 3 data. It seems to be that third. I think the interesting is it should work theoretically better because those patients have all got a positive PSMA PET scan. We wouldn't treat someone if the scan wasn't positive. So that tells you something about the biology of the tumour. The fact that even though the PSMA is positive, why aren't we getting the same responses? The more aggressive a tumour is, the faster the PSA doubling time, the higher the Gleason score initially was, seemed to make the efficacy of lutetium probably less than in someone who's got originally a lower Gleason score, less aggressive, slower PSA doubling time, less advanced state of disease. So your tumour volume is very important and where it is. So we know in nodal disease, lutetium PSMA works incredibly well. In bone disease, less so. And the more bone disease you have, the less we get durable response. So we're starting to understand its strengths and its limitations. I think the genomics and the biology of the tumour is actually it will become more important. For us, we're quite interested in making sure patients have had their genetic mutational status analysed. And I think over time we will start getting some answers on which subgroup where lutetium will be more effective. But lutetium is a beta emitter, and a beta emitter it's nice in that we've got lots of experience. We've been using lutetium now for over 20 years in different cancers. It's not great at causing what we call double-strand DNA breaks. It causes a lot of single-strand DNA breaks, and tumours, like human cells, have got repair mechanisms, and they fix those. And it appears to be when we give Pluvicto or any of these agents, we seem to get a good response first, second, maybe third cycle, and then you see diminishing returns. And that, we believe, is that we're probably subselect a cohort of cells that are just ramping up their DNA repair mechanisms. So I think we're in the very early stages of all this type of therapy. We're sort of at the bicalutamide days. We're now starting to have a look and see, well, why didn't it work? What's the biology like? How can we make it work better? Can we add something to help potentiate the effect? So adding a PARP inhibitor or something, will that actually potentiate the effect? Should we be adding some chemo in those really difficult cases? Should we be bringing in earlier? Our results seem to suggest it's earlier. There's been some work in the use of some of the novel anti-androgens in upping PSMA expression to try and improve the efficacy of lutetium. So I think we're now starting to say, okay, this is a drug that works. It's safe. It doesn't work as well in probably 50% of the patients that we would like that it should. So what can we do now? So I think what we're starting to see changing is, apart from bringing the therapies earlier, as I mentioned, combination, but also let's change the isotope. Let's move away from lutetium to something more potent. So actinium we've been using, very potent, alpha emitter, lots of double-strand DNA breaks. But with it comes more toxicity. So we're not only just getting more double-strand DNA breaks in the tumour, we're also getting in the salivary glands and possibly in the kidneys. So we're getting more damage in those organs. There's always a balance. We can give something that's more potent, but what's the side effect profile? And then if we've got something much more potent, then what population do we really want to use that in? Is it someone who's failed lutetium? Is it someone who starts off with very aggressive disease and we want to get in hard? So those are the questions that I think we're thinking about as a field, as a industry, and I think that's where the trials are starting to go. And there's been lots of new developments. There's now agents which are less salivary gland toxic. We're starting to use an interesting agent called terbium, which has got a beta emitter like lutetium, but it also has an Auger emitter, which is like a pseudo alpha. It's not really, but so you've got two radiations in one, and we're starting to see better efficacy, but very early days though. So I think this is where the excitement is in the field, and that there's all these different combinations and permutations, and we're really in very, very early days. I foresee in 10 years' time, the way we use these agents will be probably very different to what we're doing now.
One of the things that we try to do on this channel is contextualize prostate cancer as a chronic disease for patients, because you go into, the newly diagnosed stage and, maybe they do a localized treatment and then maybe they become they're hormone sensitive, the cancer comes back, they start hormone therapy, then they go into hormone resistance. But in reality, usually those treatments work for quite a long time. And even, whether it's a couple years or 10 years, you're still being grandfathered into better treatments. And the patients who were diagnosed 15 years ago, now having the eligibility for Pluvicto, if they are in that state, they've started chemo, now they're able to even have access to this. When they were diagnosed, that wasn't even an option. So in the next 10 years, to hear you say that there are so many different combinations and there's these, a lot going on in the research, it's really exciting. So, you mentioned genetic testing, we talk about genomic testing. What tests do you use, and do you think it's crucial for patients to have who are maybe looking to get a lutetium or an actinium treatment?
We look at some very basic tests. So are you anemic? We can correct that. We worry about your platelet count, because the myelotoxicity we see from radiation-based therapies is a bit different to what we see with chemotherapy. With chemotherapy, you see drops in white cell count, drops in hemoglobin. You can sometimes see some drops in platelet count, but it's usually it bounces back pretty quick. So very different with radiation therapies. We do see some anemia. We don't see that much drop in white cell count. We can see drops in lymphocytes, but interestingly, we don't seem to have a lot of the issues that we would have expected with low lymphocytes. But it's the platelets where we get it's a slower decline and more prolonged decline. We don't see a lot of that with small molecule therapy, but if someone comes in with very low platelets, then we think about it. Hemoglobin is actually relatively, you can't transfuse. Platelets are a lot harder. Platelet transfusions don't last very long. We don't have a lot of very good agents to support platelets. White cell count, we can give colony stimulating factors. It's the platelets that we're concerned about from a full blood picture point of view. From a kidney function, that has an impact. Now, Pluvicto is approved, I think, with eGFR greater than 50. We have used these agents in lower eGFRs, and you can do it safely. You may have to dose reduce, which is difficult because Pluvicto comes in one dose. But, we're quite used to doing that with chemo. If your blood counts are low, we drop the dose. But with a standard fixed Pluvicto dose, it does make it difficult to do that. The renal function is something that can be an issue, but then again, it all depends. You've got to put it in context. If someone hasn't got many options and they know that we may affect their renal function, we're not going to give them end-stage renal failure in a week or a month or 2 months. But it may take quite a long time. It all depends on the context of where that patient is in the journey, really. Whether they wanted a therapy which can not only prolong their life, but may make other symptoms much better. Whether we are willing to take the risk with what's happening with their renal function. But by and large, most patients, thankfully, aren't end-stage renal patients when they come and see us. We also now have some newer agents. The antibody that is coming out, the radio antibody, is not renally excreted. it has no salivary gland toxicity. It's not bound, doesn't bind to the saliva. So that's the Telix product, the Lutetium Telix 591, and also the Weill Cornell Actinium J591. Very exciting, different mechanism of action. They're not a small molecule. They're an antibody, so the binding's a lot better. Different side effect profile. But in those cases, when we're using the antibody, the marrow toxicity is something that we're really concerned about because we do get longer prolonged drops with antibodies. I'm quite happy to give Pluvicto to someone with a platelet count of 100. I'd be tentative in giving an antibody, or I'd have to watch them very closely. But I don't have to really worry about the kidneys. So I could have someone with renal failure that I could actually give an antibody to, which also then opens up, all of a sudden I now have different agents for a different patient population. So that is once again widening what we will be able to offer in the future once these drugs are approved. From a research point of view, we're interested in a number of different things, from circulating tumour cells, what impact are our therapies having on circulating tumour cells, to some of the genomic markers. I know BRCA is probably the one that we're very keen that everyone is BRCA tested. The US, we're far ahead of Australia in their BRCA testing program because the PARP inhibitors do offer another therapeutic choice. So I think for us that's a bit of a no-brainer. Everyone should have BRCA testing if they've got particularly metastatic prostate cancer. And I think it's been done earlier and earlier. But I think looking at some of the new genomic markers, they're still in the research world, but I think they may give us some clues as to why Pluvicto and the other PSMA agents may not work in that 1/3.
When it comes to Lutetium 177, you mentioned the possibility, even with other theranostics, that you may see it work better earlier. When do you see this being optimal? Like, I know that we live in a world where it's not covered or, it's on a trial, but when would it be the most optimal to give a theranostic?
The real answer is we don't know. A lot of our treatments are often brought in at end stage. Logistically, they're hard. They're also can be quite expensive. If you can make something work at the end of at the end of the line, then you expect it to work much better earlier down the line. But our therapies are radiation-based therapies. There is a point where you start worrying about, well, how much radiation can I give someone? We think they do work better earlier in the piece. I think there's enough real-world data suggesting that before chemotherapy, the right place for a group of patients, particularly those who haven't got highly aggressive disease. My personal opinion is if you've got someone with highly aggressive disease, then you've got to be probably looking at combinations and hitting them hard with combination rather than something like lutetium, which works very well for more indolent type disease. Pre-chemo, I think, is where we're going to see it. Earlier than that, in the hormone sensitive setting, we know it works in anecdotal real-world data where it has been used. There isn't a lot of data, but we know it works. The issue we have is those patients, as you said before, will often have 10, 15 years. And am I going to cause some problems down the line? And the thing we worry about is the damage that we may do to the DNA in the tumour, in the bone marrow. And am I going to cause myelofibrosis? Am I going to cause myelodysplasia? Am I going to predispose them in 10, 15 years' time to something related to their marrow? That's probably the biggest thing. We've been doing a little bit of work with this with some colleagues at Oxford because people's marrow, there is a genetic predisposition to damage by radiation. Some people, their marrow can't handle it. And we know there are some particular markers. JAK is a marker that may help us guide whether someone has that. But at the moment, they're not easy to pick up. You have to sort of do bone marrow biopsies, which aren't the most pleasant thing in the world. And it's only a small percentage. But when we start bringing stuff earlier and earlier, that's always in the back of our mind. Are we going to cause problems down the track? All radiation can cause secondary malignancies down the line. And we know that with lutetium therapy, at least in the neuroendocrine setting, it's more so in patients who've had lots of pre-treatment, they can develop problems with their marrow after lutetium therapy. It's not a huge percentage. It's usually less than 5%. When you have a large population, even if it's 1%, then we may be causing problems. So this is the dilemma we have. Do we think it'll work better? Yes. When's the right time? I'm not sure. Where do I think it'll go? I think it'll probably go in the pre-chemo. Possibly hormone sensitive, but we need to do a lot of work before we can say that.
Well, I mean, it's exciting that there is the possibility that we could use it earlier. You mentioned BRCA testing. So if somebody is BRCA positive, would that mean that either Lutetium-177, actinium, lead, or even the antibody would work better?
No, it's more so that if you're BRCA positive and you haven't been on a PARP, then you should. There is some data suggesting if you're BRCA positive, then in fact you may be a short responder to lutetium on its own. Now, whether you should be a lutetium plus PARP, there are some studies looking at the addition of PARP to lutetium. We don't know yet. We should have some data on that in the next year or so. There's some work being done here in California and also in Melbourne. I think we'll have some more information with respect to whether the combination of that combination is more effective. But we know that patients who are BRCA usually have got a more aggressive tumour type. Those patients, they respond to drugs, but often for not as long. And I think lutetium is in the same boat as the other drugs that have been trialled.
So when it comes to actinium versus lutetium, you know, when we talked about earlier with lutetium working in really well in 1/3, and it's kind of that 50% of patients where we do see it, how does actinium work? Is it similar? Is it different?
Now, we don't have any prospective trials yet in actinium. That's all been retrospective, mostly large cohort, real-world data. And we've also been quite fortunate in that Mike Satheki in South Africa has been able to look at some patients who are in the pre-chemo stage with actinium. He's been getting very, very good results, sort of 80-90% response rates in the pre-chemo. So not the third. What we don't know is, have we actually changed the natural history of the disease? In that if I've given actinium up front and it's worked in 80% of patients, that's wonderful. But if they relapse and then they got chemo, would they have been the same position if they'd had chemo up front and then got actinium as a fallback? So we don't know whether we've actually changed that whole 10, 15 years, as you put it. That's what we're not sure. We do see better outcomes. And even in the cases, most of my patients that I use actinium are patients who are not responding to lutetium. So in patients who don't respond to lutetium or rapidly relapse, once again, I get the same third. 30% great response, about 30% stable, and about 30% where it doesn't work. But now that's a smaller cohort, of course, because they're the non-responders. So it does work better earlier, but also you bring in the side effects earlier. You bring in the kidney trouble earlier, or the kidney damage earlier. It's not terrible damage, but it is damage, and then you've got many years of that. And you're giving the salivary gland toxicity, you're getting that earlier. And that doesn't seem to be totally reversible either. So you're left with a degree of permanent salivary gland damage. But it is a great salvage. But Novartis have got a trial that's just starting with a new type of molecule, which is supposed to have less salivary gland toxicity with actinium. So we're very excited about that because, at least from the salivary gland point of view, which is a major problem with actinium, we may have now some molecules which will minimise that. I'll be interested to see what the renal toxicity is of that agent. That's what I'm very interested in, actually.
In comparison to Pluvicto, how severe? If Pluvicto is like a 1 to 5 in the salivary glands, or maybe a 4 or a 3, and you can correct me if I'm wrong, how much farther and how much more extensive would actinium be as far as renal and salivary gland?
If 1 is very little and 5 is terrible, I put lutetium at about a 2, and I put actinium at about a 4 to 5, but it's cumulative. So most people don't have much trouble with their first dose of actinium. Once you get to the second, third, fourth dose. By about the 4th dose, patients are not happy with the dry mouth and dry eyes.
And as far as the renal glands go?
It seems to be a cumulative effect. I haven't seen patients who have gone into end-stage renal failure, but when we monitor our lutetium patients, we see very little change in renal function. There might be 1 or 2% change. Sometimes even difficult to appreciate. If we follow them for long periods of time, we may see some reduction, but then it's always hard to know, is that age-related decline? Are we speeding up that age-related decline? But with actinium, it is quite obvious that within 2 or 3 cycles, there is a definite drop in their eGFR. It does become an issue when you're starting to use these more potent agents earlier on, because as you get older, often your renal function does deteriorate over time. We're going to see problems in the future. So that's why we need to be very cognizant and keep an eye on all these. And even after it's approved, post-marketing surveillance is actually pretty important.
And what type of PSA decline do you see with actinium?
We see quite prominent PSA declines. We see more so than we do with lutetium. It is just a more potent agent. But PSA isn't the be-all and end-all. We don't see the same PSA decline, or Provenge had no PSA declines. Radium really had no PSA declines, but you still got survival benefits and good symptomatic relief. The antibody, we don't see the huge PSA declines. They're much less. But if we look at some of the survival data, the Will and Cornell survival data for the antibody is some of the best we've seen without the PSA declines. If your PSA drops and then shoots up, everyone likes to see the drop, but the rebound, I think people sometimes forget that. But if you see a PSA that doesn't have that huge drop, it just stays low, 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 it's really the area under the curve that's important. It's not, did you get that 50% drop? Did you get that 75% drop? We've sort of become accustomed to that with the small molecules, but as we start moving to different types of agents, other parameters are going to become more important. And in the end, it is overall survival and your quality of life that matters. For me, the best thing about these agents, what really gets me, is the great quality of life. Patients, yes, they want to live longer, but they want good quality. We see that in every parameter that we test. In PSMA4, it's against novel anti-androgens, it's not even against a chemotherapeutic agent. We see much better quality of life. That can't be underestimated.
This whole channel, everything that you're saying when it comes to quality of life, it's so important. Because so many times patients see oncologists, they're in the US specifically, we see our doctors for a very short amount of time. We're told that this is the treatment you're going to get. A lot of times they're not told ahead of time what side effects they're going to endure. And then unfortunately, they're kind of wondering, is this normal and is this permanent? And so I think highlighting that is so important. Now, when it comes to, you mentioned lead. So what is the lead versus actinium versus lutetium? This is exciting because I haven't heard much about this.
I can sort of break it up into interesting and novel things happening in the radioligand field. And in fact, now, you mentioned before, what's the difference between nuclear oncology and theranostics? Some societies decided that what we should be saying is actually the proper nomenclature, I've been told, is now targeted radioligand therapy. So we have a whole series of different isotopes which have different characteristics. Now, lutetium is the one we're most used to. It's a beta emitter. Clarity have got a copper-67, which is a beta emitter. But it's a shorter half-life beta emitter. And why is that important? It has a different flux. To decay with a shorter half-life means the flux of your nuclear annihilations are faster. Now, there is some theoretical potential benefit of that. That may give better killing. In animal models, it seems to suggest that. You could have a beta emitter, but just a different type of beta emitter, which may be better than lutetium. We don't know that yet. But that's exciting to have a look at. Well, there's another type of beta emitter that we could use. Then, of course, actinium is an alpha emitter. The issue with actinium is the supply has been very difficult. It's hard to make. It's expensive. There is other alpha emitters out there. With bismuth, there's astatine. But one which is gaining a bit of attention is lead-212. So there are companies now who are making lead-212, both in the United States and in Australia. And that's a very interesting agent. It has a shorter decay time than lutetium or actinium. But because of that, it has some nice properties. Once again, the flux may be important. And initial data out of the trials using a lead PSMA look very promising. So it's another type of alpha emitter, but now we have a choice. Now, will one alpha emitter be better than another? Will one beta emitter be better than another? Time will tell. But it also allows us then to say, well, as I was talking about with terbium, which is both an Auger and a beta in the same isotope, there is this interest in combining. Is it better to use an alpha and a beta? In certain cancers, do you want a faster flux? We don't know yet. So these are all the interesting things that are happening And once again, the permutations and combinations are huge of what, in fact, you could be doing. Lead-212 is an alpha emitter. It's, in some ways, easier to generate. Whether we can make enough for huge volumes, that has yet to be determined. It is a different type of alpha emitter that, in combination, or it will be used instead of, or rather than actinium in certain situations. But we've got to do the trials.
So how does the flux directly affect the patient?
The flux doesn't affect the patient per se, in that there's a belief that higher flux may lead to more DNA damage, cell kill. These are theoretical discussions. It's sometimes seen in animal studies, but we've cured every cancer known to man in a mouse. So sometimes they don't necessarily translate. What's more important in some ways, what is as important is rather than tumour kill, is does that also mean more damage to normal tissues? So that's why we need to do the trials and have a look and see what's the toxicity like with these different agents. But this is just really to show you that there's a whole range of different therapies, different companies working on different therapies and different combinations. Will Cornell have done some lovely work where they've combined a beta small molecule with an alpha antibody in the same patient. So using the different properties of the antibody with its high circulation time, exquisite binding of an antibody attached to an alpha with great double-strand DNA break, with the trusted known side effects of lutetium with a small molecule that we now understand pretty well and we're fairly comfortable with. So there's some really interesting work being done in this country and in others.
So if patients want access to those types of trials, I know we have clinicaltrial.gov here, and we'll obviously list a lot of the trials that I've read from your bio and publishing, but is there a direct way where patients should talk to their oncologist and really figure out, I would love to go on this trial, I want it, more information about it?
I direct patients to clinicaltrials.gov all the time. Australia's also got an Australian clinical trials registry. But whatever's on that should be on clinicaltrials.gov as well. It's sometimes a timing issue. They may be on one registry a few months earlier than another. But that is a source that I routinely use. And there are so many trials. And no oncologist can be on top of all the new targeted therapies. So you can't be on top of all of it. There is an organisation known as Theranostics.org, who are putting the Theranostic trials on there, if you're interested in Theranostics. But all major trials really should be on clinicaltrials.gov.
So when you talk about, greater numbers of SUV and maybe Pluvicto not being effective or any of these other treatments, what is SUV and how significant is it to prostate cancer?
An SUV is determined by your PSMA PET scan. So when we do a PSMA PET scan, we see the intensity of activity, and it's fairly routine for us to choose one or two or three sites and say, okay, what level of intensity is there? It's more done from a research point of view. Some places do it routinely as part of their reporting. Other places use more of a qualitative approach. But this is sort of a semi-quantitative measure, which is fairly reproducible. So across the industry now, particularly if you're doing things in a standard sort of way, using the standard agents on standard cameras, then it's fairly reproducible. SUV's Standard Uptake Value is a measure of the intensity of a receptor expression with PSMA. So the higher the PSMA expression, then the higher the SUV. And there have been a number of trials now looking at, at what sort of SUV cutoff do we expect the Pluvicto or the PSMA INT to work. There is a sort of a linear relationship between effectiveness and SUV, but it all depends also really on what you're trying to get. If I'm looking for the best overall survival data, then it does seem to be the higher the PSMA expression. So an SUV, a standard uptake value greater than probably 12 or 14, is where I'm going to get the best survival data. Will I get survival benefit if the SUV is 10? Yes, but it just won't be as good as 14. Will I get it if it's 8? Yes, but it just won't be as good as 10. But I think the question is, why are we using the therapy? If we're using the therapy just for survival, then that's critically important. But if I'm using it for palliation, if I'm improving patients' symptoms, so I'm improving their quality of life, I may not get that survival data, the best survival. But if I'm still able to give them palliation, then this is where it becomes more difficult, because we haven't got as strong data to say, okay, at an SUV of 9, you won't get a benefit. You may not get the survival benefit that you saw with SUV of 14 or 15, but you may still get a quality of life benefit. And that may be to you just more important or just as important as the extra few months of survival that you may receive with these agents. You can only really extrapolate that to PSMA small molecule type therapies. So when someone says, I'm going to use an antibody, my SUV is low, I shouldn't use an antibody, you can't say that. We don't know. We presume that, in fact, we should be able to use an antibody with its exquisite binding, long circulating retention and circulating time with lower SUVs. And that'll come up in the trials as they look at that data. But if you're looking purely at survival benefit, the higher SUV, then the more drug we should be able to get to your tumor.
So, you talked about the fact that we have these, lead is an alpha emitter. You have actinium, which is also, so they have a higher payload, there's more toxicity, and then you talked about betas as well. But the antibody is very different. So can you explain, just in simple terms, what an antibody is? And then, you mentioned how it's being used, but from an access issue, when can we see this being more mainstream and these studies coming to fruition so that we can get access to it?
Antibodies have been used in nuclear medicine for a number of years, but they've been used as therapies now, and they're standard in many therapies. Rituximab therapy for non-Hodgkin's lymphoma has been around for 20 years. The beauty of antibodies is that they can be humanized, because we have B cells that produce antibodies in our body. That's how we fight a number of infections. That's how we develop immunity. That's why we get vaccinated, to basically develop antibodies against potential pathogens. We know the immune system is incredibly important. We also can produce very specific molecules that bind to a receptor of interest. So in non-Hodgkin's lymphoma, when we make rituximab, that binds to the CD20 on the lymphoma. Exquisite binding. We don't really see anything else that binds as strongly to a target as an antibody. So when you look at the retention and how much dose we can deliver a tumour cell, when we look at a small molecule, be it PSMA, INT, PSMA 617 or whatever, when we compare it to an antibody binding to the same PSMA, we get more binding, we get more radiation. So in animal models, in cell models, we see better cell kill because we just get more binding there, and it sticks. The other thing about antibodies is because they have a long circulating half-life, in that when I give Lutetium 617 or Lutetium PSMA INT, what doesn't bind in the first few hours isn't going to bind. It starts getting excreted from the time it almost enters the bloodstream. What binds. And then there really isn't much circulating after sort of the first 48 hours. With an antibody, it's circulating for at least a week, maybe longer. And so that means that if a cell has got low receptor expression, I've got a better chance of getting it bound. If it's in a hidden area, so we talk about the bone or the bone marrow as being hidden sites, maybe that's why we're not getting enough therapy there, we should pick it up. You've also got to remember the bone marrow is the largest blood organ. So I'm going to get a lot of circulating antibody going through that bone marrow over the next 7, 10, 12 days. And then the other beauty of the antibody, because it's circulating for long periods of time, if you have a cell that hasn't switched on, cancer cells are sometimes in hibernating mode or they're in growth mode. Now, if it's not in growth mode, it may not have the cell expression that a growth cell has. So I may miss it. I may give Lutetium PSMA, a small molecule. It is still a cancer cell, but it hasn't turned on. If that turns on in 3 days' time, who cares? It ain't seen the Lutetium PSMA. The only way I can hope of it getting killed is if there's some crossfire or bystander effect with a cell next to it having some lutetium there, and then I can hit it because of the longer path length of the lutetium. Antibodies offer quite a different way of giving a therapy. But because of that, they also, as I mentioned, have the different side effect profile. They're circulating, so you're getting dose constantly to the marrow for that 7-12 days. So we see more profound myelotoxicity and a longer time to recover. In all the trials that we've used, and I've treated now probably around 30 patients all up on and off trial with the TLX591 antibody, radio antibody, we've seen recovery, reversible myelotoxicity. The other thing is, when we give lutetium PSMA as Pluvicto, we give 7.4 gigs. When we give the antibody, we're giving 2.8 gigs. We also give less doses. So from a cost, if lutetium is an expensive isotope, it may bring the cost down. From availability, if I now only have to give 2.8, even if I had to give it 4 doses rather than 6 doses, I'm using 4 doses is almost equivalent to just over 1 dose of Pluvicto. So we are actually saving on the amount of lutetium. So when you have a finite supply of anything, it makes a lot of sense from that point of view. Also, the Will Cornell study where they've actually combined an antibody and a small molecule, that has some really interesting kinetics associated with it. And that may be actually quite useful. Maybe the small molecule for things like the nodal disease, which we know works really well, but if you've got bone disease and we think the antibody will work better there, all of a sudden we're covering both bases. I think the antibody is a really exciting step. It's not new. We've used radio antibodies for a long time. It is an area where there is more interest. There's another company I'm working with that have developed another antibody. It will also be for prostate cancer amongst other cancers, because its target's sort of a pan-cancer target, but it'll be for PSMA negative prostate cancer. We're going to start seeing more different agents, different targets. So very exciting time.
It is exciting. I almost leapt out of my chair when you said PSMA negative, because I feel so for these patients that are in this 10% category here. And correct me if I'm wrong, but this is the number that we've seen, is that 10% of patients are in this PSA negative, aspect, and they have Axemin, and they're kind of wondering, okay, I can't take. Everybody talks about PSMA, and that's really exciting, but it's not for me. And then, when are we going to get targeted therapy? So this is really exciting.
Yeah. So there's a few agents. Novartis and Clarity have got a bombesin agent. Bombesin binds to gastrin-related peptide 1, which is upregulated in PSMA negative prostate cancer. So that's one approach. The company I'm working with have a different agent called Glipican, and that Glipican also binds to a number of cancers, but one of them is PSMA negative prostate cancer. And bombesin also binds to a number of other cancers as well. So there are some newer agents coming through looking at different targets, some of which will be in PSMA negative. But also in that PSMA, not so much PSMA negative, but PSMA low expression. Everyone talks about, if your SUV isn't greater than 10, then Pluvicto is probably not going to work that well. That paradigm isn't quite correct when you start going to actinium, because actinium is more potent. So I might be able to treat someone with lower expressing disease if I've got a more potent agent. I can probably get a response with less there. It needs to be tested. But the antibody similarly. The antibody, with its circulating and exquisite binding, maybe those patients who've got an SUVs of 4 or 5, we could still get a therapeutic effect. We don't know that yet, but that's what the science would suggest. And so it does offer hope for patients who maybe they're not great expressors. And then there are different trials looking at things like the novel anti-androgens to upregulate PSMA expression. And we've done that in patients quite successfully, in a number of patients where we see real upregulation, and then we give our therapy to try and maximise the therapeutic effect. That's the exciting thing for me, in that the way I see myself approaching patients in the future will be, what's the best agent for you? Not necessarily, okay, you've got PSMA expressing tumour and you get Pluvicto, but it may very well be, based on your genomics, your PSA doubling time, the degree of expression, maybe your best combination is a combination of the antibody plus something else. So I think we're going to be going to a much more personalised form of therapy. And my belief is we're never going to be the sole form of therapy. We don't treat difficult cancers with one agent. We used to, but we don't anymore. And there's a good reason why. Because combinations just work so much better. How do we treat lung cancer now? We have immunotherapy, chemotherapy, radiotherapy. often in combination, and we get our best outcomes. So I think combination therapies are the way we're going to go, and a much more personalised approach to how we assess someone for therapies. I think that's the future.
Are there any clinical trials currently where they are doing combination therapies with these types of theranostics, where we see it maybe with chemo or hormone therapy or anything like that?
Yeah, there is. The ENZAPI trial was combining enzalutamide with lutetium, PSMA 617. That's an Australia-wide trial. There are some trials now combining docetaxel with lutetium therapy. I think that's actually a really good combination for certain patients, particularly patients with aggressive disease. I think that is actually a smart combination. And surprisingly, it's pretty well tolerated in our experience. There are more and more interest in how we combine. I already mentioned the lutetium and PARP inhibitor trial. So, yeah, I think we're going to start seeing many more of these combinations coming through. And with the radio antibody trial, just to let people know, Telix is opening their, I think that's just about started, their Prostate Global, which is using the radio antibody, and that opens in multiple centres around the United States this year. So if you're interested, it should be on clinicaltrials.gov.
Interviewing Dr. Lenzo was very exciting. He has information and has done so much research into areas that we don't yet have approval for here in the US. We do have Lutetium 177, but he talked about actinium, he talked about lead, he talked about a new antibody, and so much more. And so we're going to go ahead and list the clinical trials in the description of this video and in the comment section, because while we may not have access, through the typical standard of care or what's approved by the FDA, clinical trials are running, and we want to make sure that you have access and awareness to those, different trials, and make sure that you can talk to your doctor about them. Now, one thing that's really important as you advocate for yourself and your case is to make sure you know your PSA doubling time, how large is your prostate, how is your, PSA acting, what treatments have you been on, and then when you have all this information, you can have better conversations with your medical team. Another way that you can reinforce your knowledge about your case is through our helpline. It's a prostate cancer helpline with patients who have been through this whole process, and they are a wealth of information, and you can learn more and contact them at pcri.org/helpline. Now, I really want to encourage you, if you're in a metastatic state, maybe you're already hormone therapy is not working for you, there are a lot of options, as he mentioned, and so these clinical trials may be a wealth of information for you, and also may be a little overwhelming. So if there is a particular clinical trial that you are interested in, you can email or talk to our helpline about it, and they can help you kind of understand it and contextualize it and get you ready for your medical appointments. So it's really handy to have that. And overall, just make sure that you get support. Make sure you bring somebody with you to those doctor's appointments. Make sure you're reaching out for mental and emotional health through this whole process, because you are important. We don't want you to be alone. You're not alone. PCRI is on your side, and we hope you have a great week.